Be a live, please.
Welcome everyone to this second episode of Refraction series. And this is going to be on subjective verification of refraction. This is our second module today. I am really thankful to my very good friend, Dr. Krishna Prasad, for taking this up. And he's very hard to get, but he's spared time for us to do this. And I think there is nobody better than the existing team who can teach you all about refraction. So I'm joined by the co-chairperson of this webinar, Dr. Vijaya Pai, again, a very good friend, always a pleasure to meet you, Dr. Vijaya, professor and senior consultant ophthalmologist, Kasturba Medical College, Manipal. And she happened to be my daughter's teacher also. So, and today is Good Purnima. So from everybody's side, I think we should wish the same.
Thank
Then
you.
Dr. Sheetal Savoor, of course, who's been a part of the first module as well, head of the Department of Ophthalmology, Yanopaya Medical College, Mangalore, Karnataka. And she's going to be speaking on subjective verification of refraction. And of course, you can say the person who's planned the whole thing and the person who's the director of this series in true sense, Dr. Krishna Prasad, Director, M.M. Joshi Eye Institute, Hubli, Karnataka. He's going to be moderating the session. And when Dr. KP was actually leaving RP Center, I wondered why did he ever want to leave RP Center and go to Hubli, but I think he's doing such a great job. And the way education is being transformed in Karnataka, we really need to be grateful to the M.M. Joshi Eye Institute in Hubli, Karnataka, for showing us so many ways, so many programs, even in AIOSSC, whether it be Teachers of Tomorrow or Student of the Year, all of them have emanated out of the programs which are done at M.M. Joshi Eye Institute, Hubli. So over to you, Dr. Krishna Prasad, and over to you, Dr. Sheetal.
Thank you, Dr. Namrata, and warm wishes of the Guru Purnima. We are all grateful to our teachers. Teachers make us what we are today. We can't repay our teachers. The only way possible is to pay it forward, to teach the next generation unconditionally. So that is what Dr. Sheetal Savoor will be doing today. So last module, we had objective refraction. We had retinoscopy and trying to get the acceptance and all the nitty-gritty of that. So the next step forward is when it really translates into a prescription on a spectacle prescription, which the person takes to an optician for finally making the glasses. There are a lot of hurdles. So that's probably a more difficult job and a very subjective one at it. So it requires a lot of science and art. And all that will be covered by Dr. Sheetal Savoor, an eminent ophthalmologist, extremely passionate about postgraduate teaching. Of course, we have Dr. Vijaya Pai, the doyen of ophthalmology of Karnataka and a very good friend. So we are expecting a very good scientific deliberations today. Over to you, Dr. Sheetal.
Thank you, sir. And again, I would say it's my privilege that on such an auspicious day as Guru Purnima, I'm getting to give this talk. And sir, I'm extremely grateful to you that in your presence, the ultimate guru of refraction, this is happening. And paying my obeisance to all my teachers, especially the senior teachers here, I would like to start right away. Hello. Is my screen visible?
Yes, ma'am. Absolutely.
So the last seminar was all about objective refraction. And often we think that, objectivity is everything. It should be more accurate. However, in case of refraction, I would say subjective verification is the king. Yes. So last time we learned about the optic cross, that where we should sit, why we should sit at that particular distance. And what distance correction we have to give, what cycloplegic to use, how much to subtract for it. So after having followed all those steps, like in this case, we have a minus 0.75 diopter sphere. While doing the refraction at 2/3 of a meter, for which we are subtracting a minus 1.5 for the distance and minus 0.75 for cyclopentolate. And we get this refraction. It should be right eye. So anyway, we are very excited to get this diagnosis, compound myopic astigmatism against the rule. So in all fervor, the glasses are prescribed and low. Just a week later, the patient comes back dissatisfied. What could have gone wrong? So it's very easy, like I said, when you do an objective refraction because you're in control. But in subjective refraction, we require the patient to be very cooperative. Not only that, the distance paradox, as sir always says, you may think you've done at 1 meter, but it might be at 2/3 of a meter, or you may have gone even closer. The cycloplegic drops that you used, okay, you didn't wait long enough, or the drop didn't enter the eye enough. You were in a hurry, so you did it fast. Or the child may have had pseudomyopia and a spasm of the ciliary muscle, and therefore didn't relax the accommodation completely. Also, issues with the trial frame. You may have kept the trial frame too close to the eye or too further from the eye than what actually the spectacle would be worn by the patient. And sometimes we would tend to use multiple lenses, a sphere, a cylinder. So the vertex distance, of course, will matter in higher powers. Next comes the financial issues. So many times people like to spend on fancy frames and glasses. I think it might be as expensive as silver or gold now, the kind of glasses. So they're not going to forgive you if the correction is less than satisfactory. Of course, right now for the postgraduates, the exam is the most important thing. Remember, senior examiners, they always want to make sure that you know your refraction right, because that is how you're going to start your career, and wrong refractions will actually jeopardize your career. So please remember that this is a very important part of your exams. So now that we know what is the importance of subjective refraction, the only situation I would say where you will not do a subjective verification is if the child is too young and you do it under general anesthesia, or the patient is mentally incapable of, telling you whether he's comfortable with the correction or not. So retinoscopy, I would say, is a starting point or just a guide, whereas subjective correction is the king. So I have covered upon these points. One more point is when we use the autorefractometer, often what happens is the patient tends to accommodate. Also, the head may be tilted and the axis may not be accurate. So now coming to the most important point, that is the end point of subjective refraction, is the strongest plus or the least minus needed to achieve the best visual acuity. So let's try to understand this a little better. This patient is having myopia of 3 diopters. That means if the eye requires 60 diopters to focus on the retina, this patient is overpowered by 3 diopters, 63 diopters. So what is happening is the rays are converging in front of the retina. So what do we do to correct this? We will use a concave lens which will diverge the rays so that an image is formed on the retina. However, sometimes we can get a little excited and try a minus 3.5. And the patient is seeing better, still seeing 6.6 with it. You get even more excited. You say, let me try a minus 4. And you're, again, patient is seeing. So you think, okay, maybe I should give the patient a minus 4 prescription. Mind you, actually emmetropia was achieved at minus 2 diopters, but now you are prescribing minus 4. And what is happening here is because the rays are now coming to a focus behind the retina, the ciliary muscle is going to accommodate, the lens will swell, like you see, it's going to become fatter than what it was, and try to bring the focus on to the retina. So when you constantly use this accommodation, naturally the eye is going to get tired. Imagine you go to the gym for a few hours and lift weights, it's all right. But you can't, move around whole day carrying some 20 kgs weight, right? This is something like that. You cannot put the ciliary muscle through this stress all the time. And a clue here is the optotypes get smaller and brighter. That time you should think you have over-minused. Let's take this other scenario. Here the patient has hypermetropia of 3 diopters. You can see that the light rays are converging behind the retina. That means the eye is underpowered. So suppose 60 diopters is required to focus the image on the retina, then the patient has only 57 diopters. And so the rays are behind the retina. So what are we going to try to do? We will use a convex lens and try to see that the rays are converged on the retina. However, at plus 2.5, you realize that the patient is reading the 6-6 line, although he needs a plus 3 correction. But you're quite ignorant at that point in time. So you think, oh, patient is reading 6-6. Why not give this correction? So what is happening here is, again, the accommodation is active and that tries to place this image on the retina. So the patient is seeing clearly by accommodating. So again, like I said, you can't put the eye through constant stress. So the patient is going to come back dissatisfied after some time. So if you've given, let's say, a 0.5 diopters of overcorrection of myopia, then the patient is going to accommodate 0.5 diopters for distance. Now, if this patient wants to read at 40 centimeters, he's going to require 2.5 diopters for it. Mind you, now he has to use the additional 0.5 diopters also, which he's using for distance vision. So where he needs a 2.5 diopter correction power, he is now using 3 diopters of power for accommodation. Okay, now coming to the holy grail, that is the Sturm's conoid, and this is very important or vital to understand astigmatism and its correction. So I would like to cover the basics first, and then we'll go to each type of or each method of verification of subjective correction. Okay, so in Sturm's conoid, you have 2 meridians. Now they are not curved equally. One is more curved than the other. Here the horizontal meridian is more curved. Therefore, it is coming to a point focus on the retina. Actually, it's not a point focus. It's a line of focus. Okay. So at this point where the horizontal rays are converging, the image is a focal line because the vertical rays have not yet converged. So the image is a vertical image. And then the vertical meridian that is less curved is going to come to a point focus beyond this. So you can see that at that point, the horizontal line is clear because the horizontal rays have converged and then they have started diverging again. So this interval between the first focal line and the second focal line is called as the conoid of Sturm. And there is this interesting little circle called as the circle of least confusion. Here, the amount of convergence is equal to the amount of divergence. And hence, it's like a circle. And this is of a lot of importance, as you will realize soon. So this circle of least confusion gives the best compromised vision. Okay, please remember the word compromised vision because it's not ideal. Okay, what we call as the spherical equivalent. Then next, coming to the concept of fogging. Now let's try to understand this using the Sturm's conoid. So when we fog the eye, we are adding a plus power. And what we try to do is we try to move this term conoid in front of the retina. So what we are essentially trying to do is we are trying to create a myopic astigmatism. Now, how does that help creating myopia or myopic astigmatism? So the more the patient is going to accommodate, okay, the Sturm's interval is going to be pulled further away from the retina. So the vision is going to become blurred or more blurred. So what the patient will try to accommodate once and realize it's blurring more. So patient is not going to accommodate. Patient is going to relax his accommodation. So we will come to know the true refractive error without the influence of accommodation. And this is very, very important in the subjective verification of. Next, coming to the Jackson's cross cylinder, a very simple, useful, inexpensive tool that has to be in your OPD. So how does this work? This increases or decreases the interval of Sturm. That is how it works. And the most important point to note here is it is made in such a way or it's constructed in such a way that its spherical equivalent is 0. So what that means is this little interesting circle of least confusion does not move. It does not have an effect on it. Next, coming to the astigmatic dial. So here what we do is when we are trying to identify which line is clear, it is the line that is closer to the retina that it is seen clearly. Then what we try to do is we will collapse the interval of Sturm. That is the two lines will come close to each other by using a negative cylinder. And that is how we are going to correct the astigmatism. So now I will start with astigmatic dial or fan because this is the simplest method. It's very elegant and very fast too. So we will come to know more about the cylinders using this simple technique. Now let me ask you, since I have mentioned about the Sturm's conoid, which of these two lines do you think the patient will see clearly? It is the vertical line as marked here. That is because that's the one that's closer to the retina. In this case, the patient would see the horizontal line better because that is closer to the retina. So this astigmatic dials, as you can see, okay, it has many radial spokes. So if a patient has no astigmatism, then all of it is going to appear equally blurred or equally clear. So what we are going to do while we use it is, first we try to look for any uncorrected cylinder, or in case we already know that there is a cylinder by doing retinoscopy, then we are going to try and refine it. So the first step or one of the most important steps for any subjective correction would be to fog the vision. And as I explained earlier, what it's going to do is it's going to prevent the patient from accommodating, because if they try to accommodate, the vision becomes blurred. Also, the patient is going to see a bigger line. So if he was seeing 6/6 or 6/6 parts with subjective correction, now he may see the 6/12 or the 6/18 lines. So it becomes easy for the patient to make out any subtle differences which he might miss if the vision was, say, 6/6 parts. So then what you're going to ask the patient to do is report which of these spokes or lines are clearer or darker and sharper. And you got to note this axis. Next step would be to insert a negative cylinder perpendicular to this axis till all the lines appear equally blurred. So let's assume that 180 degrees was clear. Then what we do is we put a negative cylinder at 90 degrees, and the end point here would be when all the lines are equally blurred. So then we have got the correct cylinder. Then we slowly defog in small steps to refine the sphere, and the patient then will have satisfactory correction or subjective verification. You see, this is the end point where all the lines should be equally blurred or clear. Next would be the stenopic slit. This is nothing but an elongated pinhole. So what do we use the pinhole for in vision? So when vision improves with pinhole, it's actually the rays that are going to pass undeviated and fall on the fovea. So we'll know the potential visual acuity. Up to lower refractive errors, it can improve the vision, but in higher refractive errors like aphakia, etc., the vision will not completely improve with the pinhole. This stenopic slit is an elongated pinhole. It allows only the rays that are parallel to this opening to pass through. The other rays are blocked. So this is primarily used where the cornea has irregular astigmatism, as in a peripheral corneal scar post-trauma, post-corneal ulcer. So in a patient in whom the retinoscopy reflexes may be confusing, the AR refuses to give you a clear value because the surface is not very regular, that is the time the stenopic slit will come to our rescue. So basically what we are going to do is ask the patient to wear we are going to place the stenopic slit in the trial frame and ask the patient to rotate it until he can see clearly. So that is going to be the principal axis. And then we can add more power or less power until the patient sees relatively clear. Now, he cannot be expected to have very clear vision. So you will note that number. And again, you can repeat this at the second meridian too. And by doing this, you can come to know the sphere as well as the cylinder. So this is used in special cases where we can't use the other methods. Again, a very, very simple equipment, but it can be useful where other methods are not very useful. Now, I would like to talk about Jackson's cross cylinder. Actually, it seems quite daunting when you don't know the theory behind it. But once you understand the concept and you realize that it's after all not so difficult, you will really enjoy using it. I think definitely KP sir is instrumental in making refraction phobia to refractionophilia. So anyone who listens to his lectures or is mentored by him is definitely going to fall in love with refraction. I can say that for sure. Okay. So what is a cross cylinder? As the name suggests, okay, it's a combination of two cylinders, as you can see. There's a minus cylinder and there's a plus cylinder. Okay, they are opposite sign but same or equal strength. And how are their axes oriented? They are perpendicular to each other. Also note that the handle is at 45 degrees from the axis. So what is the prescription of a JCC? So a 0.25 JCC, how is it made? It has a plus 0.25 sphere and double the strength. Okay, the cylinder is twice the strength and of the opposite sign at 90 degrees or to it. So why is it so? Remember, I told you about the spherical equivalent. Correct. So if you add half the power of the cylinder, that is minus 0.25 to the sphere, that is plus 0.25, what do you get? 0. The spherical equivalent is 0. It would be the same with any prescription, a 0.5 JCC or a 1 JCC. It is built on the same principle, wherein the cylinder is twice the strength of the sphere and at 90 degrees. Again, as I mentioned earlier, the JCC does not move the circle of least confusion because the spherical equivalent is 0. So it acts by increasing or decreasing the interval of stem, as you're going to see it in the next slide. So the picture on the left, okay, the interval is very large. So can you see this huge circle of least confusion? So it becomes larger and the patient reports blur. Now, what happens when you collapse it or when you reduce the size of the Sturm's interval? It becomes smaller and the patient reports clearer. So this is how it works. Now, another caveat here is, if you increase the power of the cylinders, power mind you, that is when the circle of least confusion will move away from the retina. And what is your job here is to put it back on the retina. And how do you do so? You add half the cylinder power with opposite sign to the spherical power. By doing so, you are placing this circle of least confusion that has moved because you have increased the power of the cylinder. You are going to put it back on the retina. So another point is, very important point I would say, is to remember to always refine the axis first. And why so? Because if the axis is wrong, you cannot determine the correct power, but vice versa doesn't hold good. So axis always first. A is first, right? So axis always first. And if you have a choice, you always use the higher power JCC for axis determination and the lower one for defining the sphere. So let's see how this is done. So like I said, for any subjective verification, you have to fog the eye with a +1 that will reduce or blur the vision. The patient will see a line that is bigger than before. And also, it's going to discourage the patient from using refraction, his accommodation. The next step would be to straddle the cylinder. How do we straddle? I'll be showing you with images. You place the handle along the axis of the test cylinder. And what this does is it plays with the interval of Sturms. It will either increase it or decrease it. When you increase it, patient will say it is blurred. When the interval is decreased, patient is going to say it is clear. So you flip the cross cylinder, note the position where the octotypes are darker or sharper, and then move the test cylinder along the cross cylinder of the same sign. Okay, so this is so easy. So alignment of the test cylinder and the cross cylinder. You see the handle is along the axis of the test cylinder. Okay, so it is straddling the axis. And when we another point to remember is when you're refining higher cylinder powers, remember you have to move in small amounts, that is 5 degrees. If the cylinder is lower, maybe you can move in a little higher numbers, that is maybe 10 to 15 degrees. So what you have to do is keep on flipping it, keep on repeating this until the patient says it is equally blurred. When we want to refine the power, okay, you can clearly see now the orientation is different from what it was before. It is axis to axis. Okay, the axis of the cross cylinder and test cylinder are parallel. So this is a video showing the same. At the fog, first refine the axis, place the handle or straddle the axis of the test cylinder, ask which is clearer. So now it's a minus cylinder. So you will rotate it towards the same side on the cross cylinder. and the end point is patient says it is equally blurred or equally clear, then what you do is then you remove the fog. Remember, the spherical correction is in place, and then recheck that the patient is having the most comfortable vision. Okay, so coming back to the main point, strongest plus or weakest minus, which gives the best visual acuity, is what we are aiming for. This is also for the duochrome test. So duochrome test is to refine the sphere, and it is done at the end. And here, because we are refining the sphere, we are not going to use the fog. For all other methods, we are going to fog the eye. Here, we are not going to fog the eye, something you should remember. Now, let's try and understand the interesting principle of duochrome test. It's available in all the charts, and I think one must always do this before you give your final prescription. Okay. Another important point to note here is it can distinguish or it can refine only small amount of sphere. That is only 0.5 diopters plus or minus. It has to be done in someone who has good vision, 6/9 vision and no problem with the macula. The other interesting thing is that you can do it in colorblind people also, because you're not testing color vision here. You are just testing the hues and asking which one is sharper and darker. And this should be performed both monocularly as well as binocularly. So if the difference is more than 0.5 diopters, okay, for example, actually, if the patient's refractive error is a minus 2, okay, and you're giving a minus 3. So there's a 1 diopter difference. That is not when this is going to work. So it's reliable only if there's a 0.5 difference. So the famous mnemonics RAM and gap, okay, for red add minus and green add plus, I will tell you the basis of it, so you don't really have to mug it. It's very easy to remember. So the whole concept is based on chromatic aberration. That means different wavelengths of light. Okay, the incident rays are bent to a very different extent based on their wavelengths. Okay, and the retina is at the midpoint of the spectrum in an emetropic eye. Okay, so this is the chromatic interval. That means the interval between green and the red. Okay, if you convert it to diopters, is 0.5 diopters. And so that is why I said if the difference is more than 0.5, this test becomes unreliable. Okay, so if you could answer this question, which color do you think that emetropes would prefer? Do you think it's red or do you think it's green? Okay, so I'm sure you all might have answered it right, that there is no preference because both are equidistant from the retina. Okay, now can you tell me which color would myopes prefer? So in this case, it is red, obviously, because the red is closer to the retina. Okay. So what happens here is you use a concave lens so that the rays are more divergent and push the interval behind so that the red and green straddle the retina. So the end point is both of it should appear equally clear or equally blurred. So now you will know why red add minus. So when the patient is seeing red, okay, red is closer to the retina, you want to push it behind. So you will use a concave lens in order to push this term's interval behind so that the patient sees both equally blurred. So which color would hyperopes prefer here? Obviously now green. And when you put a plus lens, okay, both of them are going to straddle the retina and therefore its endpoint is equal blur. Next, coming to binocular balance. So this is done as the last step after you have refined the cylinder, and then you do the sphere, and the final test to do is the binocular balance. This is very important, but definitely many of us are guilty of not doing it because we didn't know much about it. So once you know, you must ensure that you do this binocular balance for every patient. So why is it done? To ensure that the accommodation is relaxed in both eyes equally. So here again, we are going to fog the eye, and then we have to dissociate the vision of the two eyes. So how are we going to dissociate, and why are we going to dissociate? So the reason for dissociating is you want to simultaneously compare the vision in both eyes. Now, when we test vision, we are testing only one eye at a time. We are not testing both eyes at a time. And for whatever reason, when one eye is being tested, the accommodation being used may be different in one eye and it may be different in the other eye. So finally, at the end, when you're giving a prescription, if you haven't thought of equalizing the accommodation, the patient is not going to be happy with the glasses. And how do we dissociate these two eyes? So we are going to use a vertical prism, which will induce a vertical diplopia. A 10 or 12 diopter prism in one eye we can use, or we can split the prisms between both the eyes. For example, a 5 prism diopter base down in the right eye and a 5 prism diopter base up in the left eye. So you know which image belongs to which eye based on the orientation of the vertical prisms. So I will repeat it again. The idea here is to simultaneously visualize what each eye is seeing, which you cannot do otherwise. And then you see which of these is clearer. Suppose the patient says that the line that you are showing, the test line, is clearer with the right eye. Then you have to add a plus 0.25 sphere in that eye. So this is the prism to be used. So for example, if the patient is, you're testing the right eye and the patient has -3 diopters of myopia, then you cover that eye and then you test the left eye. And here, instead of -3, the patient is accepting -5 because for some reason, the patient would be accommodating in the eye under the cover. And therefore, because of that, there is higher accommodation happens simultaneously in both eyes. So if the right eye is accommodating under cover, the left eye is also going to accommodate. And then instead of -3, the patient may accept -5. But if you're going to give -5 in the left eye and a -3 in the right eye, that is not the correct power. Again, there is going to be imbalance because either one eye has to accommodate or one eye has to relax. So it's not going to be balanced, and the patient will never have simultaneous good vision or comfortable vision. So this is what happens, that the eye under cover for whatever reason may accommodate, and because of Herring's law, the eye that's being tested also could accommodate, resulting in over fineness or under plus. I did briefly mention the word vertex distance earlier when I was talking about the why subjective refraction becomes important after objective, because when we were testing, we may have kept the trial frame at a certain distance from the cornea. Okay. And why should this matter? That is because maybe the trial frame was at 12 or 14 mm from the cornea, but the spectacle is being worn at some other distance. And when the power is significant, more than 4 diopters plus or minus, then the effective power of the lens is also going to change. And then obviously patient is not going to get the power that he actually needs. So what should we do? We should compensate for this vertex distance. So if you can see in this, okay, it's a +8 diopter sphere. Okay, now if it is moved away from the eyes, this same lens has a power of +8.5. Actually, the power has not changed, but when you move it away from the eye, the brain perceives as if this is a lens of a higher power. Similarly, when you use a concave lens, it works the opposite. If you take it closer to the eye, the effective power increases. But if you move it away, it appears as if this lens has lesser power. Mind you, it's perceived power. So this could be the reasons why many patients may be finally unhappy, because you have not corrected the vertex distance, especially in higher refractive errors. And also this is the reason why the power aphakic correction differs with different planes. So the power of the IOL will be different from a AC IOL or a iris claw versus a contact lens or aphakic correction. And this matters most in contact lenses where the vertex distance is 0. So coming to the final part, that is a few tips for subjective refraction. So I cannot stress more on this: strongest plus and weakest minus, which gives maximum comfortable visual acuity. So first you verify or refine the cylinder by either using the cross cylinder or the astigmatic diode. Then you refine, and here also the axis first and then the power. Then you verify the sphere by doing a duochrome test. And here you're not going to fog the eyes. And remember, it is sensitive only for a small amount, that is up to 0.5 diopters of sphere. And finally, but importantly, both the eyes, you have to balance the accommodation by a very simple technique where you fog the eye and you use a vertical prism to dissociate both the eyes. So these are some practical tips. Like they say, don't change what ain't broken. So if a patient is very happy with his current glasses, maybe the axis is not what you calculated or the sphere is not what you think it should be, but don't change it if the patient is happy with it. Never prescribe a large cylinder for the first time, because often, the patient children especially will not accept a very large cylinder. So give the least cylinder with which the patient gets comfortable vision, and then subsequently you can slowly increase the cylinder so that the acceptability is better. The other very, very important point here is regarding correction of near vision. So if we are overzealous and give a very high reading addition, we are forcing the patient to relax the accommodation. So a practical tip here would be to see that you give the least plus at whatever working distance. So you have to know the working distance of the patient, correct it. And after that, make sure that the patient can see clearly in a short range of distance. So you move the near target a little away and then move the target little towards the patient. By doing so, you're trying to ensure that there is no overcorrection or undercorrection and that the patient has good range of near vision, because most people do, they have tasked at different, reading distances. So they will be comfortable. So reassess the need for bifocals in myope, because myopes, the near point is close to the eye. Often because of that, they can read without a problem. They're not used to using their accommodation. But when you correct them, you make them e-metro, they have to accommodate for near. and they're not used to, the ciliary muscle cannot work efficiently. So what happens is they will be very unhappy. So it is good to undercorrect these myopes and give them good near vision. And maybe eventually, as the accommodation becomes stronger, then you could give more correction. So make sure that when you correct myopes for distance, you always check their near vision to make sure that they can read. This is especially in children. You don't want them to stop reading at all because they find that it's cumbersome now. Why? Because they need to use accommodation. And can they use accommodation? No, they're not used to using it. So this is something, always check near vision when you are correcting a high myope for distance. So with that, I come to my last slide, and I'm very grateful to Krishna Prasad sir. He's been a mentor to me. He has helped me, and I would like to acknowledge that. And this is a topic which even I felt would be difficult, but I think maybe he helped and guided me. So this is how I could try my best to simplify this topic. It did take a lot of effort from my side, but it was very enjoyable. Thank you so much for the opportunity. And sir can give his comments, and so can the others, and we can take some questions.
Thank you, Dr. Sheetal. Sheetal means cool. It was a cool presentation, very well covered. But I would like to just add a few more things just to reiterate what has been told so far very elegantly. See, all postgraduates should know that accommodation is very firstly, I would like to say there are two C's and two are M's in the accommodation spelling. Okay, starting with that, accommodation is such an important thing that you should understand. See, human eye has an ability to change its overall dioptric power by actually altering the shape of the crystalline lens. This is a human lens. That's how it works. So for that, three things are important. Number one, it is about the contents of the lens. From birth till adulthood, the contents of the lens change. Its flexibility, the plasticity, the content, the color, the pigments, the hardness keeps on changing. In a very young patient, it is so fluid, so plastic, and so flexible that whenever left on its own, it will assume a spherical shape. So this is important. This memory of this material, of the lens material, which changes with time. The number two is the most important factor in the accommodation is the capsule and the zonule. The capsule and the zonule is the most important part of this mechanism. So the capsular changes, the rigidity of capsule, the zonular weakness, they keep on getting added year by year. And finally, the ciliary muscle also develops some amount of, poor performance with time. Putting all this together, the eye cannot actually change the shape. So we lose our accommodation amplitude. So the amount of maximum accommodation that can be done by any human eye is called as amplitude of accommodation, measured in diopters. It can be basically got by the near point of accommodation. So the closest point to the eye, which can be seen clearly by maximum accommodation, 100 divided that in centimeters gives you the dioptric power. So like in a 2-year-old child, it is not very good at birth. It gets developed by first 1 to 2 years. By 2 years, we have maximum accommodative amplitude in terms of its functionality, something like 15 to 16 diopters. So when you have so much accommodation, but still, if you do not use it properly, you get into trouble. Remember one thing, accommodation is only for near work. You cannot use this accommodation for far distance. So whenever you start using it for far, you get into trouble. It's a misuse, abuse of accommodation. So this is very important. So as Dr. Sheetal said, the strongest plus and the weakest minus, which gives you the best visual acuity, should be prescribed. The underlying fact is when you use the strongest plus and the weakest minus, you are not abusing the accommodation. You are letting it free for near work. Let us say If you use a weaker minus, if you don't use the strongest, let's say strongest plus, I said, let us say if you probably lessen that plus power, if you don't use the strongest one, what happens? You need to chip in that with your accommodative kitting. If you increase the myopic power for whatever reason, instead of giving -2, if you give -3, that one diopter has to be made good by accommodation. So you are basically making the accommodation to work for a wrong purpose if you don't use the strongest plus and the weakest minus. And this becomes a very difficult issue whenever the patient is accommodating too much, especially in young people. See, accommodation, the children tend to use accommodation. So hyperopia is never an issue in smaller magnitudes in children because any amount of hyperopia will be made good by accommodation. So they accommodate, the distance becomes clear. So they are basically misusing the accommodation for distance. But a smaller amounts of hyperopia, they can always use the accommodation because they have a lot of accommodative amplitude. So there is no problem. But as the accommodation keeps on dwindling, then this becomes a habitual problem and there will be a shortage of accommodation for near purpose. So this is where in refraction, you should never put the accommodation into stress. So that's a very important thing. And in case if you are not able to fog and relax the accommodation of the patient, please feel free to do a cycloplegic refraction so that you take away that element of accommodation and you basically understand what is the actual refractive status of the eye, how it has been modified by accommodation. You may probably get in your retinoscopy +3 as the retinoscopy findings. But if you probably put atropine, you may get +7 or +8, which means to say that around 3 to 4 diopters of hyperopia has been made good by accommodation. So this is a very specific usage of cycloplegia. Do not overuse cycloplegia. You don't have to mandatorily use cycloplegia as a ritual because you are back to square one. Many a times your subjective may be difficult. You get a cycloplegic refraction, patient comes back for a PMT. Again, your patient is accommodating, you are back to the square one. Only thing is you have the knowledge of what is the refractive status, which is useful in certain situations. So this is something very important. And astigmatic dial is the most underutilized, very elegant method. You can just have those radiating lines at a, near next to the Snellen's chart. See, when you are finishing your subjective correction, for a small cylinder which might have been missed, or the patient probably is not 6'6", he's 6'6" parts or something, and you are not able to figure out why it happens, you just fog the eye with +1. All the radiating lines look equally blurred. That only means that there is no cylinder which is lurking. It can be the simplest thing. If any of the line is more sharper than the other, then you have to put a negative cylinder along that axis. But the least you can do is put a +1, see whether all lines are equally blurred or equally clear. That itself will clear you of that any other possibility of a cylinder which has not been detected. And she spoke about the stenopic slit. See, pinhole and stenopic slit are two very important things in your trial set. Stenopic slit is an elongated pinhole. See, in a scarred cornea, let's say a patient has a corneal trauma or an adherent glaucoma or a central nebular opacity. In that patient, the vision is grossly reduced, very grossly reduced. So in that situation, your AR will not give you any reading. Your retinoscopy will have scissor reflexes. You dilate the pupil, put the patient on the Snellen's chart, put a stenopic slit, let the patient only rotate the stenopic slit so that on which axis he sees the best visual acuity. That gives you the axis of the principal axis of the cylinder. That means there is an astigmatism which you can't discern by AR or retinoscopy. But now you know that at 76 degrees, he's seeing better. That means that can be one of the axes. You try plus cylinders, you try minus cylinders around 76 and keep on adding plus or minus spheres. It's basically an elaborate surgical subjective correction, but you can probably get up a very good refraction or a subjective correction, which you can't otherwise do with objective methods. So stenopic slit also helps us. the direction at which or the quadrant at which we can do an optical iridectomy. Let's say there is a central corneal opacity or an adherent glaucoma. Sometimes we enlarge the pupil to create an optical iridectomy. In that situation, you put a stenopic slit in a dilated pupil. Let us say at a particular axis, he sees the best. That is the quadrant in which you need to enlarge the pupil. That is the axis in which there's the least aberrations or irregular astigmatism. Not anywhere. Along the axis, the stenopic slit sees the best. So that can be one of the other uses that we can actually do it. At the same time, the best one, of course, Dr. Namrata Sharma is here. Best thing for an adherent glaucoma with a clear pupillary area is a scleral contact lens. A scleral contact lens will take away the irregular astigmatism, will take away the aberrations, will create a new surface, and you can get very good visual acuity if there's a small corneal opacity which cannot be corrected with spectacles. Scleral contact lens, which will completely replace the irregular corneal surface with a very spherical and a regular contact lens, rigid contact lens surface. So this is something which has to be kept in mind. And lastly, the binocular balance. See, there are a lot of kids who accommodate too much. The AR always comes as high minus numbers, even though they don't have so much. They may be 6 otherwise, but they keep accommodating. They always accept -1, -2, -3, and variable refraction every time because they are not able to relax the accommodation. They may have a lot of problems at home or school, or they may have some kind of a psychiatric problem sometimes. There may be in the residential school. So you have to understand the psychological background of the child, why it is not able to relax. It may be under some kind of a mental stress. Such children, binocular balance is very important because they keep on accommodating. -2 they accept in one eye, suddenly they accommodate in the other eye, they may accept -4. And if you prescribe the glasses, then they will not be able to see clearly because you cannot accommodate asymmetrically with that glasses. So just put a fog, put a prism so that you see two Sneller's charts. If both are equally clear or equally blurred, that means the perfect is fine. So this is an area where binocular balance helps, where you're expecting the child to accommodate and derange the results of your refraction. I think we have Dr. Vichya Pai. She has an extensive experience in teaching postgraduates refraction. And we are all basically the old school people who will believe in refraction, not in our optometrists or autorefractometers. So over to you, Dr. Vijaya, for your insights and what PGs have to do to strengthen their refraction training so that they do well in the exams as well as probably the bigger exam, that is the real life practice. Over to you, Dr. Vijaya.
Thank you. First of all, I would like to congratulate Sheetal. She has made it so simple and interesting. It's easy to catch the most important points. As you said, we belong to the old generation. Agreed. But how many of the present generation know to use the lenses in the box? Our teachers used to say, the refraction is the bread and butter of ophthalmology. I think it may not be applicable anymore. And there were instances where a candidate failed because the lenses were not kept properly in the trial frame. So, I mean, the students should understand that they may be seeing only difficult and complicated cases during their course. But once they start practicing, it is a refraction that matters. So only one thing I would like to add is that whenever we change the spectacle prescription, we must make the patient understand that it may take some time for the patient to get used to the new glasses. So that has to be stressed upon. And second thing is that, I mean, there are so many things also matter, choosing the frame, the interpupillary distance and all. So all these things should be there in the prescription because we know that it is, we give the prescription, patient goes and buys the glasses. How the glasses are made, it's not in our hand. However, if the patient is not happy, the patient comes back to the ophthalmologist. So this is all I would like to add on to whatever Sheetal has said. So PG should understand that refraction is important. It's only during the exam they do something, some values they add, and they say that's it and forget it. Thank you, Sheetal.
Thank you, ma'am. AP sir, are you here? I don't know if there are any questions that need to be addressed. We'll just wait for a minute, perhaps. Ma'am, meanwhile, maybe I will ask you a question. What is your suggestion? Like, how should postgraduates sort of progress in their refraction year-wise? What would be a good suggestion from you? Ma'am, I think you're muted. You're muted.
As a postgraduate, we had 1 month posting in a refraction room. I think at least make them post them in the refraction room at least for about minimum 15 days in first year and maybe in the second year once they understand it better. So that is must. They have to have a posting and they have to maintain a logbook of their retinoscopy and what is the prescription given. So at least they will understand how they wrote the prescription.
Can I answer you? May I also answer, Sheetal?
Yes,
I
sir.
think I have for the beginners at least, or not exam going maybe, I think it's important to fall in love with refraction because a lot of things can be tested on yourself or on your friend volunteers. It is not like knowing how to, I mean, you can't have to take a peribulbar block to know what it is. It's a refraction basically. So take a trial set, take a trial frame, sit, try to understand what is say each refractive error means. You put a trial frame on your face, I mean, block the right eye. If you're a metrope, then try putting plus lenses which mimic myopia. So, with 0.5 myopia, 1 myopia, 2 myopia, what is the degradation of vision? Because sometimes I ask, what is the visual acuity of an uncorrected -1 myope? Most PGs cannot answer. Okay. So they have to first check. At the same time, how to create a hypermetropia. Put minus lenses so that you become hypermetrop, but you can still accommodate and see better. So you can actually try those things on yourself. The physiology works for you also. So you can try that. Put a cylinder number and see how astigmatism affects with the rule, against the rule. You put a plus cylinder 90 degrees, 180 degrees. So you can create multiple models of refractive errors on yourself. We don't have to need any volunteer on yourself. So to understand how actually it appears. So if you're already, and if you must be having a lot of friends with refractive errors, so take a retinoscope, keep doing retinoscope on them, multiple people, so that you can work at 2 meters distance and try to see how the refraction changes. Work at half meter, try to see it changes. So all these things, as I said, you can do binocular balance on yourself. You can do a Jackson cross cylinder on yourself. You can do a duochrome test on yourself or your friends. If you do not have more patients or subjects, or you may probably not having the resource to do it on patients, do it on yourself. No, post work hours, you can always try to do. It's a hands-on thing. Refraction is never theoretical. It's a hands-on thing. Whatever we have discussed here, everything can be understood hands-on on yourself, on your patients. So that is something which so once you start doing that, you will understand. Okay, for example, I was just talking about today about 4-prism diopter base out test. See, unless you do it on your friend, like what is the normal response if you put a 4-prism diopter base out and what is the movement? See, it is something that you can always do it on your friend. No, why wait for a patient? So at least understand the normal response. Instead of writing the theory about 4-prism diopter base out test, why don't you do it on your friend and find out what happens? So lot of things in ophthalmology can be done on yourself so that you understand. So this is a very enchanting thing. I think refraction or giving good spectacles is not the duty of optometrist or the job description of optometrist with autorefractometer. At the end of the day, the accountability is yours. The onus is on you, because patients are spending a lot of money in making spectacles, and any dissatisfaction arising out of that, nobody will be held accountable except you. So especially you talked about very elegantly on Jackson's cross cylinder. For example, patients who have oblique astigmatism, especially higher degrees of astigmatism, if you do not do any cross cylinder verification, or if you do not do an astigmatic dial, they will not be very happy, because they're going to make a spectacle worth 25,000 rupees, and if your cylinder is wrong, and who is going to refund that money? Number one. Number two, we are doing progressive glasses. A lot of people who are presbyopes with very complex refraction, with a lot of oblique cylinders, if you probably err in giving cylinders, then the progressive glasses, the entire thing falls apart. Patient will not be able to accept it. So my earnest request is, postgraduate, don't have a myopic view that it is for the exam. We always tell you that in the beginning of the class to get your attention. We always tell you examiners know it, so you better learn it, otherwise you will be in trouble. That is just a phobia that we create to draw you into this. But look at the bigger picture. The bigger picture is the patient sitting in front of you tomorrow in practice is your biggest examiner. Okay, this examiner may take mercy and pass you, and he is going to fail you mercilessly, because he will say, you don't know how to give glasses. How will you do cataract surgery? Okay, so basically our evaluation comes from giving good glasses, and being a person myself with refractive, I know how good it is, or how satisfying it is to give a good correction. So please understand the principle, understand the optics, and please do a hands-on thing. And at the same time, refraction should be a strong point. You can make a mark. Most people do not know it well. I think if you probably learn it from your heart, practice it, that will be a strong point. It will be a biggest, your, what I should say, trump card for your success in practice. So postgraduates, start doing it. Sky's the limit. And at the lastly, she talked about a very important point. I wanted to talk about that, the vertex distance. See, vertex distance is the distance at which your spectacles actually sit. So please make sure that you put a trial frame at the appropriate place, normally where the spectacles sit. If you put it too much on the nose away from the eye, and whatever correction you give, it will be extra, especially in a larger powers, it will make a big difference. So as she said very correctly, plus numbers, when they move it down the nose, they become more powerful. So we used to have earlier patients who used to undergo cataract surgery without IOLs. They were wearing aphakic glasses. Plus 10 was the usual prescription we used to give. They were not using bifocals. They were using monofocal plus 10 lenses. If they want to read a newspaper, they would actually move the spectacle down their nose. That means a plus 10 would become plus 12 or plus 13 when it goes away from the eye, and they were able to read it. Similarly, myopes, for example, myopes in the pre-presbyopic or the early presbyopic age group. Somebody is wearing -4 for distance. He's, let us say, 39 years. He's getting early presbyopic symptoms. So we have to now give him a progressive glasses. You have to give an ad of +1 or something. Instead of that, what he will find out is, if he actually puts it away from the eye, on the nose, if he slides it down, a -4 lens will become -3. It is like adding +1 to his near correction. So a lot of myopes in that age group put it down to see near. A lot of aphakics put it down to see near. So this is how the vertex distance changes the effectivity of our spectacle prescription. So this is very important. And you always know, when you move towards the nodal point, the plus power, for example, +10 aphakic glasses will be around +13 or 14 contact lens, and at the maybe the iris plane it may be around +20, maybe in the bag it may be around +22. So the power keeps, for the same refractive correction, for the same effectivity, for the same visual acuity, the powers keep changing. That is the influence of vertex distance. So make sure that you know this difference when you use a contact lens practice, how the power changes. For example, a -10 spectacles will be around -9 contact lens. It is the other way around. Whereas a +10 spectacles will be +13 or +14 contact lens. So this has to be understood so that you make corrections for the vertex distance. I think it has been a very exquisite, exhibition of the entire deliberations. Dr. Sheetal Savoor has done an excellent job on the subjective verification. We still have 2 modules left, a fortnight away as well as in a month away. So we're going to cover other aspects of refraction. And Dr. Namrata Sharma has given us an idea that this is going to be turned into a course actually once the recordings are done completely. So, Dr. Namrata, are you around? Okay. So, anything else, Dr. Vijaya, we need to add before we close?
That's all I can remember. I don't think the spectacle frame and all is beyond this, I think.
No. Today we're only talking about subject. We have other talks coming next. So,
More bad.
so to end it up, basically give the strongest plus, weakest minus. Check the cylinder. You can have Jackson's cross cylinder, astigmatic dial, spherical correction with duochrome test. Basically, spend time at the subjective, take your own sweet time and see that. And whenever you have a suspicion of an accommodative overactivity, please do a binocular balance test and make sure, don't believe any optometrist. Always check the prescription, check the correction before you write it down on the prescription, because it is finally your onus, you are accountable for it, and that will result in a happy patient. So subjective verification is the king, objective verification is the guide. So with which we close this webinar. Thank you so much for all the people who have attended online, and we will meet you after 15 days with other very important topics like presbyopia correction. We have low vision aids and so many other topics coming up in the subsequent 2 modules. I thank Dr. Namrata Sharma, our Chairman Scientific Committee of AIOSSC, and the entire AIOSSC for giving us this opportunity. Dr. Sheetal, me and Dr. Vijaya Pai, okay, together we want to thank AIOSSC for the opportunity. Thank you so much.
Thank you, sir.
Thank you, Dr. Sheetal. Thank you, Dr. Vijaya.
Thank you, sir.
And we will meet after fortnight.
Good night.
Good night.
Thank you, sir. Good night.